Regarding cancer and COVID-19 epidemiology, the data on this patient subgroup are limited, but the National Comprehensive Cancer Network, NCCN, has referred to early available data from China that has reported patients with cancer and COVID-19 were 3.5 times more likely to require mechanical ventilation, intensive care, or have a fatal outcome compared with those with COVID-19 without cancer. The American Society for Clinical Oncology, or ASCO, refers to the report of the WHO China Joint Mission on Coronavirus Disease, which indicates a 7.6% fatality rate for patients with cancer as a comorbidity to COVID-19, as compared with a 3.8% fatality rate of those with COVID-19 and no comorbidities. ASCO also refers to an article published in The Lancet by Liang et al. That reports a higher incidence of severe events in patients with cancer and COVID-19. An NCCN review of strategies for treatment decision-making begins its discussion by reviewing the importance of triage and masking of patients with respiratory signs, which also might extend to a triage by phone for patients with mild symptoms. According to ASCO, there is no evidence for guidelines for N95 mask use in an asymptomatic patient group, but it supports following the CDC's guidelines on mask wear. In light of the CDC's recommendation that elective surgeries be postponed, ASCO advises that in some cases, such as early-stage breast cancer, it may be reasonable to delay surgery and start neoadjuvant therapy, but advises that the risk of tumor progression should be weighed in this decision. It's also pointed out that in cases where neoadjuvant therapy requires more frequent facility visits or is immunosuppressive, related risks to the patient should be considered. Of course, please do check all the guidelines on that situation if you're caring for patients with cancer. Regarding the clinicians and healthcare workers treating patients with cancer, the NCCN review discusses strategies such as strict stay-at-home protocols for ill hospital staff, along with a return-to-work policy and tracking system for staff under investigation and staff exposures. They also recommend creating a single web page for staff where all COVID-19 related measures and policies can be easily accessed by staff. The European Society for Medical Oncology, ESMO site, recommends, in addition to PPE, dividing the cancer healthcare team by shifts corresponding with the 14-day incubation period of the coronavirus to maintain healthcare staff health. Again, given the decreased resources in staff, delays in treatment should proceed on an individualized basis depending upon the treatment goals. Treatment adjustments should consider whether delays in treatment might result in a patient's admission to an already expended facility, for example, for palliative care. For patients who have solid tumors, planned adjuvant therapy as intended curative treatment is likely better to begin despite infection risk. Delaying treatment for those with metastases could lose the window of opportunity to treat. However, several months of endocrine therapy to allow for a delay in surgery may be appropriate. For patients with poor prognoses who become infected, require hospitalization and mechanical ventilation in the face of limited resources, there's an even greater need for proactive end-of-life and palliative care discussions with cancer patients. ESMO recommends that the risk of infection with continued services to patients with cancer be considered on an individual basis, but that generally the benefit of continued therapy is thought to outweigh the risk of infection. In addition, increased web or phone consultations with and support of patients is also encouraged. The Oncology Nursing Society also has proposed that telemedicine, home infusions, and routine follow-up postponement be considered on a case-by-case basis. But again, postponement of treatments is generally not recommended for most patients with cancer. Radiation therapy may be delayed where patients are receiving this treatment for symptom control or in cases where the risk of harm from radiation therapy delay would be minimal. Withholding of immunosuppressive therapy, such as chemotherapy and or immunotherapy, or regimen alteration has not been supported by the data and is not generally recommended. But for patients in deep remission and those treated with maintenance therapy, discontinuance could be considered. Also, transition to an oral from an IV form of chemotherapy to decrease facility visits may be feasible, but would require ensuring patient adherence to the prescribed regimen. A hiatus from chemotherapy might also be considered in facilities located in high transmission zones, or administration of chemotherapy at a removed satellite facility could be considered. As far as prophylaxis, there is no evidence supporting the use of prophylactic antiviral treatment in immunosuppressed patients.